to all, and I welcome Professor Arvind Bagga sir on this digital platform to deliver a talk on steroid-resistant nephrotic syndrome, which will face sometimes a therapeutic challenge in day-to-day practice. Well, colleague, in fact, when we think of a clinician, researcher, teacher, and source of inspiration to many pediatric nephrologists of the country and abroad, the one name comes in our mind, Professor Arvind Bagga, who is the head department of pediatrics and division of pediatric nephrology, AIMS, New Delhi. And under the dynamic leadership of Professor Bagga sir, ISPN has formulated many guidelines in last about 1.5 decades, but steroid-resistant nephrotic syndrome is really a challenging task, which we published in 2021. And after sir presentation, Dr. Shubhankar Sarkar, I welcome him also from the ICH Kolkata, who will present some case scenarios related to the topic. So with this brief introduction, sir, we are thankful and grateful to you, sir, that you consented for this presentation on the digital platform for the benefits of faculty members, fellows, PGJR, and young trainee in the pediatric nephrology. So welcome, sir, and I again request you to start the lecture. Professor Bagga, sir.
Thank you, Dr. Mishra. Thank you for your kind words. It's a privilege to be able to speak to all of you through this medium of the Indian Society of Pediatric Nephrology. I'd like to thank the executive committee, Professor Susan Uttap, Dr. Aditi, Jitendra, and everybody else for making this such a good workshop, such a good training session, And so we'll be continuing in many ways of the talk on nephrotic syndrome that was taken last week. And we'll be talking about only one aspect of nephrotic syndrome here, which is the steroid-resistant nephrotic syndrome, which fortunately is just about 5 to 10% of all the nephrotic syndrome that we see. So for many postgraduate students, you would probably see these patients while you are getting trained, but you may not see so many patients who've got steroid resistance once you go into your own practice and so on. As said by Dr. Mishra, the Indian Society of Pediatric Nephrology, the KDIGO, as well as the IPNA, have been coming out with guidelines on these diseases, on both sensitive as well as resistant, and over the last 2 decades. In the last meeting, we were told that the definition of nephrotic syndrome is relatively clear. So proteinuria that's beyond a gram per meter square, a low level of albumin, which we are now defining as anything less than 3 grams per deciliter, and edema. Now, edema is at times people say even if there is no edema, you can still call this nephrotic syndrome, but there are some issues here. But then broadly speaking, the definition is this. Dr. Aditi did mention last time that a patient is said to be steroid sensitive if there is complete remission within 6 weeks therapy with prednisone, and then we'll talk about this in the next slide. And we also know how to define frequent relapses and steroid dependence. Now, what is steroid resistance? Steroid resistance is obviously the converse of steroid sensitive. So somebody who does not show complete remission, and the word here is complete remission, which is trace or negative proteinuria, or despite 6 weeks of daily steroids, the Indian Society of Pediatric Nephrology would define this as having initial resistance, as having steroid resistance. Now, there has been some controversy, whether we should say lack of remission by 4 weeks or 6 weeks. Our old guidelines did used to say 4 weeks, and the IPNA and KDIGO have kind of left this a bit vague by saying 4 to 6 weeks. I'm not going to go into details, but clearly our guidelines are a bit more clearer here that we are defining it at the end of 6 weeks. This also, matches with the initial therapy of nephrotic syndrome, 6 weeks daily and 6 weeks alternate day. So we would think, that one should be defining complete resistance as a lack of complete remission despite 6 weeks of daily corticosteroids, that is prednisone, in the right dose. In this figure below, just show you that almost 94 or 95% patients who are likely to respond would respond by 4 weeks. And the benefit of delaying therapy for another 2 weeks is just about 3 to 4%. It's not major, but nevertheless, so we'll be defining resistance here. At times, there's a question that do we need to give methylprednisolone pulses? Again, there is no consensus on this. Most experts across the world do not give. Apart from some people in Europe, majority would not be giving methylprednisolone pulses for defining steroid resistance. The definition for defining steroid resistance is slightly different in adults, as is shown in this small box here. So there you would be defining resistance at the end of 16 weeks of therapy. Just one second. Okay. Now, what proportion of patients who have got nephrotic syndrome do show steroid resistance? And again, it's a variable number. If you look at prospective case series, the figure is close to 10%. So about 5 to 10%, or maybe some studies show 5%. But the overall systematic review published a few years ago did show that in prospective series, that the about 10% patients would show steroid resistance. If you look at retrospective series, that are kind of case series from individual centers, clearly the proportion is a bit higher. But again, here you would expect that there would be a referral bias. So there is an initial resistance, which you define as lack of response to initial therapy with corticosteroids. But there is also a condition known as late steroid resistance, which is in a child who has previously been doing well on corticosteroids, and now he stops responding. And there is, and despite giving 6 weeks therapy, he does not show remission. So this is defined as late steroid resistance. These patients would have both minimal change as well as FSGS on the biopsy, but minimal change more often. And they appear to do a bit better compared to patients who have got initial resistance. We'll discuss about this in a minute later. Now, how do you evaluate patients who come to you with steroid resistance? And I'll take some time going over the slide. Obviously, you would do a urine exam, looking for RBCs in the urine. Could this be a proliferative GN? One should try to quantitate the urine protein either on basis of a spot urine to protein creatinine ratio on a morning sample, or at least do a 24-hour urine protein. So whichever is more convenient, one could follow. For young kids, you can do a ratio, but again, please try to do an early morning sample. Blood counts, looking at the renal functions, the creatinine, looking at the blood albumin, electrolytes, sugar, because some of these patients are going to require calcium urine inhibitors. So you need to be sure that there is no underlying diabetes, and the same is true about HbA1c. Now, HbA1c becomes important, particularly in children who have been on long-term corticosteroids and now they show late resistance. So you really want to be sure that there is no inherent tendency to hyperglycemia, and therefore you would do a HbA1c as well. Look at the cholesterol and triglycerides. If we have time, we'll address this also. Look at the calcium phosphate, SAP, and also look at some common serologies in all these patients. Please, I again want to emphasize this would be the evaluation of steroid resistance. For a steroid sensitive child that you are seeing, you don't need to do all this. There you would just need to do a urine exam, a creatinine, albumin, and so on. You don't really need to do HbSAg or a HCV and so on in a steroid sensitive nephrotic syndrome, or the first episode of a steroid sensitive apparent steroid sensitive nephrotic syndrome. Similarly, ultrasonography of the kidneys should be done in steroid resistance. It's not required in the standard sensitive nephrotic syndrome. The other message is that apart from doing all these investigations, including quantifying proteinuria, all children with steroid resistance should undergo a kidney biopsy. The likely pathology that you would find in about half is FSGS, and in the other about 30-35% would be minimal change. The only situation where you may not want to do a biopsy are one or two situations. One is a newborn, where you don't want to do a biopsy so early on in life, because and again, genetics there is more important, and we'll talk about that in a subsequent slide. But the only other caveat is that if you have got familial steroid resistance, or if you've got extrarenal features, and we'll talk about this soon, that suppose the patient has ambiguous genitalia, where you know what the underlying pathology would be. So here you would perhaps defer the kidney biopsy at the onset, particularly with familial resistance, or where you already have a genetic diagnosis in another sibling, then you don't need to do a biopsy. But the majority, I would imagine, almost 90% patients with steroid resistance would undergo a kidney biopsy. Apart from showing the underlying histology, the kidney biopsy would also show the extent of tubular interstitial damage. Now, this is important, which all the residents should know, is that it's not the severity of FSGS, but it's the severity of the tubular interstitial damage that determines outcome. So if you've got a lot of tubular atrophy and so on, that's the more important factor that determines outcome than the presence of, say, 10% FSGS or 20% FSGS. Furthermore, you're going to put these patients on calcium channel inhibitors, and these are nephrotoxic agents, so you want to have a baseline biopsy. And finally, there could be something that is not what you expect to find. So you could be having an IgA nephropathy in a patient who has urine showing RBCs, or you could even have C3 glomerulopathy. So these possibilities can just come up, and so be prepared. And because here the therapy would be totally different. We will not be covering the therapy of these conditions here, and maybe we can discuss them in question answer and so on. So there is, all children should be undergoing a kidney biopsy. eGFR should also be estimated, and the eGFR, as has been discussed in the initial talks, would chiefly be an estimated GFR based on the serum creatinine and the height. So that you have a baseline eGFR before you embark on specific therapy. Now, this is not really meant for postgraduates, but at times, depending on the kind of histology that you see on FSGS, it may have some prognostic information. So if you find you may have a perihilar lesion, the perihilar FSGS, as you can see here, from where the hilum is entering the glomerulus. The opposite of a perihilar lesion is a tip lesion, where the prognosis is very good, that's called a tip lesion. Or otherwise, you can have FSGS all over the glomerulus, and it's called not otherwise specified. And very rarely, in about 10% patients, you may have a collapsing FSGS, in which, you have a hypertrophy of the parietal epithelial cells, of the visceral epithelial cells. And because you have got this hypertrophy of the visceral epithelial cells, the glomerulus collapses. This has got a bit more difficult outcome, and this is the one that's related to HIV and so on. Another thing that we look at, when we are looking at the kidney biopsy, particularly for fellows here, is that you try to distinguish whether there is diffuse versus segmental foot process effacement. And if you were to look at what Geetika taught us, foot process effacement is what you see on electron microscopy. And if it is diffuse, that indicates a more generalized disorder versus segmental. And we'll talk about the importance of picking this up in a subsequent slide. Overall, if you have hypoalbuminemia and edema, on the EM, you are likely to find diffuse foot process effacement much more commonly than segmental foot process effacement. The other thing, that's become quite important in the last, I would say, close to 25 years, has been the role of genetics in steroid-resistant nephrotic syndrome. There are almost now close to 90 genes that are known. So some of them are depicted here. So you could have the slit membrane genes, you could have genes involving actin regulation, genes involving actin binding, and so on, the CoQ biosynthesis, the nucleoporins that are affecting the nucleus, and then, the integrins that are affecting the GBM podocyte interface. So you could have almost a large number of genes, and it's been seen that if you look at sporadic initial resistance, almost 25% of 1 in 4 patients would have an underlying genetic cause. And we'll talk about the importance of this in a minute. In addition, there are some other genes which typically cause tubular disorders like cystinosin. LPOT is not really a tubular disorder, but even, den disease and so on, which can at times, mimic, which can present as phenocopies of nephrotic syndrome. And so one should be aware, and all these genes should be in your panel. Most genetic labs that would be examining the genetics of nephrotic syndrome would be looking at all these genes. So it's okay, that 25% of initial resistance has an underlying cause. What about late resistance? Overall, we would say, that in late resistance, the likelihood of finding an underlying cause is extremely minimal. And clearly, you don't need to do genetics in a patient with late resistance. So somebody who has been steroid dependent for years, and now he gets resistance, I would not be too much keen in doing a genetic study in this child. So while we talked about that 25% figure, there is some data to say that perhaps, it's not as high as 25%, And there could be a referral bias, when large groups of people are talking about this 25%. And the study on top is data from GOS, the Great Ormond Street Hospital, a recent paper where they showed that just about 10% of patients who have non-syndromic, non-familial, the classic sporadic resistance would show an underlying mutation involving standard genes. So perhaps it's not as high as 25%. It could even be lower depending on where you're practicing. What about data from India? This is data that's still being prepared. Hopefully will get published in a year or so. This is data on almost 200 odd children with initial steroid-resistant nephrotic syndrome, where we looked at a multitude of genes and where we found that it's not 25%, it's more like 15%, and with a wide confidence interval. So perhaps it's not reaching as high as 20% or 25%. Within this group, we found that there are certain high-risk groups wherein, the likelihood of picking up an underlying cause is higher. So if you've got familial steroid resistance, onset of nephrotic syndrome in the first year of life, particularly in the first 3 months of life, patients who show syndromic features, and we'll talk very briefly about this in the next slide, patients who show syndromic features, patients who do not respond to standard therapy with calcineurin inhibitors. Now, all these patients would have a higher risk of picking up an underlying genetic cause. So this is really our, our focus when we are doing genetics. Now, what about syndromic forms? And this is a slide which is gifted by Moin Salim, who is a very eminent pediatric nephrologist working in Bristol in the UK. And I'm sure you have heard about all these conditions: Dennis rash, Frazier, nail patella, and so on, Now, all these patients would have nephrotic syndrome along with some other syndromic manifestations. And when you see them, think about underlying diseases, and all these genes are again well defined. Now, this is not an exhaustive list, and this slide is almost 10 years old, So you can imagine that the slide is almost threefold higher now. And clearly, there's a multitude of genes that may cause a syndromic kind of nephrotic syndrome. So if you have syndromic steroid resistance, one would always do genetics in preference to doing kidney biopsy. Now, why is genetics important? Leave aside the upper part, but this is really an update on data from various large centers that are looking at genetics of nephrotic syndrome and how it affects the management. So there is data from the whole of Europe, from Italy, Japan, this is UK, and then there is data from a very large amount of data from US and China. Our data is not included here, but again, so almost close to 5,000 odd patients, and you are seeing overall the genetic cause in these cases or case series is about 25 to 28%. I did tell you, that there is always a bias, so clearly perhaps the real number is a bit lower than this. Now, why is the genetic cause important? If you look at the response of these patients to therapy, to immunosuppressive therapy, there is a 4 times likelihood that they will not show response to any form of therapy. So patients with the underlying genetic cause will not show a response to any form of therapy. And furthermore, they are at a 3 times higher risk of kidney failure on the short or medium term. So clearly defining genetic versus non-genetic is important in context of steroid-resistant nephrotic syndrome. The other thing that's obviously you need to do genetics, because clinically you can't distinguish. They have similar clinical features, similar histology. The histology is not different. The only thing is that they will not respond to calcineurin inhibitors, and we'll talk about that in a minute. They show progressive kidney failure. The good thing is that patients who have an underlying genetic cause do not show a recurrence of disease following transplant. And we'll talk about this at the very end. Patients with FSGS, when they are transplanted, they are at a almost 30% risk of having a recurrence of disease, which is sinister, But patients who have got an underlying genetic cause do not recur. Our current policy is not to give immunosuppression to these patients who have got an underlying genetic cause. And we just consult the parents and we would manage these patients with supportive therapy. The IPNA guidelines, IPNA is the International Pediatric Nephrology Association. Given that 25% of patients would have, with initial resistance, would have a genetic cause, they would say that all patients who have initial steroid-resistant nephrotic syndrome should undergo genetic screening. Now, given that our figure is close to 15-20%, and genetics is not that easily available, we have defined certain high-risk groups. And Subhankar will be talking about this later when he discusses patients. And I've anyway told you, so there are these high-risk groups with early onset, syndromic features, family history of steroid resistance, non-response to CNI, etc. We would probably do genetics in this group first, and rather not do it in all children. I'll very briefly talk about this slide, but maybe maybe we could even skip this slide. I think it's okay. Go ahead. Once you are treating nephrotic syndrome, once you are treating FSGS or say even any steroid-resistant nephrotic syndrome, and you start therapy, the message on this slide here is that even if you get some remission, it is good. The data in the top 3 Kaplan-Meier's talks about data from the Podonet registry, which is almost 1,500 odd patients. And you can see here that even if you get partial remission, complete remission, partial remission and non-response, the ones in which there is no response, they do the worst as far as kidney survival is concerned. So clearly getting even partial or complete remission is obviously very good. The same is true if you look at the various causes. So if you compare this to sporadic steroid sensitive disease, where the outcomes are very good, versus steroid resistance, the outcomes are poorer. Then the worst outcomes are really seen in the genetic causes. So where you have an underlying genetic cause, they would progress to kidney failure quite rapidly. Similar data is there from Dr. Gibson's unit in the US, where again there's a large amount of data again showing that if you get partial response or complete response, the outcomes on the long term are not very bad. So even getting a partial response is good on the long term, and therefore it's whatever therapy you use, it would be important to be able to achieve partial remission. Now coming at the end to therapies, what therapies do you give? The drug of choice or the drugs of choice that we currently have are the calcineurin inhibitors. They are, and interestingly, they are the only single group of drugs that have been shown in multiple trials to be second to none, and they are clearly the best step forward. So once you have steroid resistance, a patient needs to be on either cyclosporin or tacrolimus if he has FSGS or minimal change disease. About 50 to 70% patients would show a complete or a partial response. Most kids would respond by 12 weeks, and the majority, and almost all by 6 months. And if there is no response by 6 months, we would often say that you can stop the calcineurin inhibitor. So the response would usually happen by 2 to 3 months. However, if you stop CNIs, either tacrolimus or cyclosporin, the majority would relapse. This is data from the Cochrane, the recently published Cochrane systematic review that looked at the updated data on cyclosporin and or tacrolimus, clearly showing that when you use CNIs, the likelihood of complete remission or any remission is clearly better than compared to a comparator. Between cyclosporin and tacrolimus, there is nothing to choose very much, and they have perhaps a similar efficacy. The only thing is about side effects. We know that cyclosporin can cause gingival hyperplasia, it can cause hirsutism, which may be tough, for an older child, particularly for an adolescent. Tacrolimus can cause hyperglycemia, a slightly higher risk of seizures, and so on. But it all depends, so one would have to weigh. Very often, if you have an older child, one would often prefer to use tacrolimus, provided there is no family history of diabetes. He has a normal sugar himself, Cyclosporin we normally prefer for young kids, chiefly because, cyclosporin is available as a syrup form. And you can give it as a syrup, and tacrolimus is not. So children below the age of 3 to 4 years, you cannot take a capsule, but we would prefer giving cyclosporin. But overall, our preference is chiefly to tacrolimus. Dr. Subhankar will be talking about this, the next slide, the next line, that do keep toxicity in mind, and particularly the toxicity, the nephrotoxicity in mind when you're advising these drugs on the long term. In addition, these calcineurin inhibitors have lots of drug interactions. And again, Subhankar will be covering this in this presentation. So keep drug interactions in mind, particularly with anti-epileptic drugs, antifungal drugs, antitubercular drugs. So the KDIGO says, that one should assess the response with CNI by 6 months. If there is no response, one should stop therapy. Because clearly, there is no benefit. The benefit, if it had to happen, would have happened by 6 months. If a patient does show a response, so if there is a complete or partial remission, one would give a minimum of 12 months therapy. This is what KDIGO says. However, our guidelines generally say 2 to 3 years. So if a child does respond, we would give for a minimum of 2 years, at times even 3 years, because as soon as you stop, there is a high likelihood of relapses. Suppose you can't use a calcineurin inhibitor, which is unlikely, given that the drug is so freely available. But if there are major cost issues, or if there's some kind of a reason why it can't be used, can we use anything else? The only other agent, where we have enough confidence using, some confidence using, not in similar confidence, is IV cyclophosphamide. But if you look at this study, which examined cyclophosphamide versus tacrolimus, while tacrolimus did lead to remission in almost 80% patients in this study, cyclophosphamide was only 46%. So clearly, it's an inferior modality, and one would not prefer using IV cyclophosphamide as a first line or even as a second line agent. Just to say here, that some patients who do not respond to CNIs do not respond to cyclophosphamide either. So clearly, there is no logic of trying to use cyclophosphamide in somebody where a CNI has failed. There is enough evidence in the literature, at least 2 or 3 trials, that say that one should not be using oral cyclophosphamide in patients with steroid-resistant nephrotic syndrome. The evidence is too limited, and the benefits are too limited. So as of today, the best and perhaps the only drugs that we have for resistance is tacrolimus or cyclosporin, and cyclophosphamide is perhaps the second line agent. For fellows in the group, or for the ones who heard the last talk on steroid-sensitive nephrotic syndrome carefully, is there a role of mycophenolate mofetil? Now, mycophenolate mofetil, is an important drug for steroid resistance, for steroid-sensitive nephrotic syndrome. But for steroid resistance, there is limited role. The 2 or 3 situations where it can be used, number one is either the initial therapy, and as you can see here, both the NIH trial as well as the Podonet retrospective data did not show any benefit of using mycophenolate as the first line therapy. The other situation where it can be used is when you have given a calcineurin inhibitor for say 2 to 3 years or 1 to 3 years, and now you want to switch to a less nephrotoxic drug. There one can try using a mycophenolate switch after giving cyclosporin for say or tacrolimus for 1 year or 2 years. But do keep in mind that once you start a patient on mycophenolate, some patients would relapse, and the likelihood of a relapse is higher than if they were continued on CNI. But the problem is you really don't want to give a CNI too long, and so at 2 years or 3 years, we start thinking about switching therapy. I would not use I would not use any therapy if somebody has got a GFR below 40 or 50. Although ICNA does say, that if you've got a GFR below 30, you can use mycophenolate, but I don't agree, So clearly, I don't think there's any indication to use. So the main reason to switch would be CNI therapy for 1 to 3 years, or if a patient, once you stop CNI, he's having steroid-sensitive relapses now, and you want to use mycophenolate for that reason. Now, this is a very small group of patients which we are discussing in this slide. What happens to somebody who shows a non-response to CNI? So you've got a FSGS who's you tried using a CNI in the right dose with the right level and everything, and 6 months later there is no response. What next? And I think here we are totally lost, because there is no clear evidence. Obviously, one would do genetic studies unless you have already done them before. So definitely do genetic studies before going further. And now you've got 2 options. One option is to combine the tacrolimus or cyclosporin with mycophenolate and try giving this for the next 3 to 6 months. The efficacy is about 25% for either complete or partial remission, which is not great. The other option is to try using rituximab, which probably on case series, as you can see here in a systematic review, they showed that 50% do show complete or partial remission. Although it's said 50%, but when you really use this in practice, it's more like 30-35%. It's not really close to 50%. So clearly, this is a worrisome group. And one does get extremely, unhappy if a patient with steroid resistance does not respond to calcium inhibitors, because we know that subsequent therapies may or may not work. I must say, however, that in children these therapies work, particularly if rituximab does work in somebody who has got steroid resistance before and now he was not responsive to a CNI and you gave rituximab, if it does work and if it does go into complete remission, these kids do well. So clearly, there is enough reason to try these agents, but very, very cautiously, and it has to be done in a tertiary care setting where you've got a pediatric nephrology support and so on. There have been other therapies that have been tried, and that they have been given up. ACTH, there was a time where there was a lot of enthusiasm, but ACTH even does not work for minimal change, So leave aside steroid resistance. So clearly, although there are some RCTs that are still going on, I can't imagine ACTH coming in a big way. Abatacept has been used in one study that was published in NEJM in 2013, but all other data has been poor, including our own experience. Adalimumab has been used as a TNF. Adalimumab, I think it's TNF. Yeah, adalimumab has been used in some trials again, with limited benefit and limited what I think there's no benefit. So again, adalimumab has chiefly been given up. There is some promise in doing LDL apheresis. LDL apheresis is by using a plasma filter, using an LDL filter. You do about 10 or 12 exchanges using an apheresis unit. And some centers, particularly in Japan, have shown that a proportion of patients would show complete or partial remission. However, I still think that we need more data on this before one can really advocate this. The only specific therapy, that can be used in some steroid resistance is CoQ10. So if you've got a pathogenic variant in either CoQ2, CoQ6, and I think perhaps CoQ8, any of these genes, one can try using CoQ10. And there was this paper in Kidney International just last year, where they showed that clearly there is a benefit of using CoQ10. The good thing, this is oral therapy. The good thing is also it's available in our country and not very expensive. But you can't do this for all steroid resistant, just limited to patients which have got a pathogenic or a likely pathogenic variant in the CoQ pathway. Now, the last one or two slides. Clearly, once you have steroid resistance, you're using tacrolimus or cyclosporin. There is the other important drug that you need to use is either use ACE inhibitors or herbs. There was a time, when we were combining the two, but this combination is not too good because, you've got significant adverse effects with hyperkalemia and so on. So we do not advise the use of the combination. So you can either choose ACE or herbs. We normally begin with ACE, either enalapril or ramipril. If a patient has cough, he's not tolerating and so on, one can try using any of the herbs. So either losartan or irbesartan or whatever. There is some data in children as well as in adults that sparsentan, which is not yet available in our country, but which blocks both the angiotensin 2 as well as the endothelin 1 pathway, is better than a herb alone. So there was a trial comparing sparsentan to irbesartan, where they showed that there was a more reduction in proteinuria when you use this. But please keep in mind, that both ACE herbs or whatever else you decide to use, they would reduce proteinuria just by reducing GFR. There is some effect, I know, also on the glomerular permeability, but chiefly it's on the GFR. And the reduction is to the tune of about 30-40%. So again, you need to do this on a diet that is low in salt. You can't give a high salt diet and give ACE or herbs. They will not work, And use the right dose, give it for a good enough time. I'm sure you are aware about the precautions one needs to take when one is using ACE or herbs. The other group of agents, that you are likely to see more reports are the SGLT2 inhibitors. And there is data in adults that the SGLT2 inhibitors, both DAPA as well as EMPA, DAPA is available in our country, does reduce proteinuria in proteinuric CKD and delays progression of chronic kidney disease. The data in children is still being evolved. There was a recent report in Kidney International last year, and there's a trial currently happening at the institute where we are looking at the role of SGLT2 inhibitors. But clearly, in adults, they have already made their place, and they are being used a lot as an anti-proteinuric agent. So I did mention to you, that once a patient with steroid-resistant nephrotic syndrome progresses to end-stage kidney disease, and you end up transplanting this child, they are at a slightly higher risk of getting the same disease immediately post-transplant. Most recurrent FSGS happens in the first 2 years after transplant, and it can happen even in the first week after transplant. So clearly, this is a problem that one needs to talk to parents before one embarks on a transplant. Now, there are some high-risk situations, where you may get. So I don't need to. Please don't bother about all these pictures. But if you have a patient who has late steroid resistance to begin with, so he was initially steroid sensitive, and he probably had an immune basis to the nephrotic syndrome, and now he goes to chronic kidney disease and requires a transplant. If you transplant this child, there's a very high risk of post-transplant recurrence. So initial steroid sensitivity predicts post-transplant recurrence. In fact, initial response to even calcineurin inhibitors predicts post-transplant recurrence. So be aware about this complication. As I told you before, if you've got an underlying genetic cause, the likelihood of recurrence is extremely low. And if you do get recurrence once, there is clearly a very high risk of getting a recurrence again. So this is a problem, that pediatric nephrologists have to manage. The good thing is, that even if you get a recurrence, the disease can be controlled quite rapidly in the majority. So while this sounds ominous, but can be managed with prompt therapy. So we won't go into details, too much details here. This is the last slide. So these are our guidelines published in 2021. So if you have a steroid-resistant nephrotic syndrome, you would do genetic testing in some specific settings, which we have discussed. Shubhankar will be talking about them again. One would do kidney biopsy in almost all patients, except certain situations. If you already have a report that says that there is an underlying monogenic cause, we would just manage these patients with ACE inhibitors or herbs, and talk to the family, tell them that there is going to be a risk of end-stage kidney disease, and manage these patients on the long term without immunosuppression. We would reserve immunosuppression for patients who have got steroid resistance, where either there is a non-genetic disease or you did not do genetics, chiefly because they did not satisfy the criteria of requiring genetics at the onset, which would be a very large proportion of children with idiopathic sporadic steroid resistance. And our first-line therapy would chiefly comprise of CNIs with tapering steroids. One would use ACE inhibitors, manage the edema that was discussed last time, assess response at the end of 6 months. If there is a complete or partial remission, one would continue using CNI for 2 to 3 years, and later either switch to rituximab or to mycophenolate mofetil, or to just stop therapy if they are doing well, and hopefully these kids will do well. The problematic group is the ones who do not show response to 6 months of CNI. There one must do genetics again. One should do genetics in this group of patients, consult the family well, and then either choose rituximab or a combination of CNI with mycophenolate mofetil. The ones who do respond, as I said before, they would tend to do well on the long term. But the ones who do not show response, they have to just manage with supportive therapy. So I'll stop here, Dr. Mishra, and maybe Subhankar can continue, and we'll take questions. If there are questions on the chat box, I'll meanwhile continue to answer them. Thank you very much.
Yes, sir. Thank you very much, sir, for your brief and excellent presentation on the topic. I hope that it must be very useful to trainees and audience. Now I request Dr. Subhankar Sarkar to present the case scenario. As up till now, sir, there are no questions in the chat box. We may take some discussion at the end of the case scenario presentation. Dr. Subhankar. Yeah.
Okay, I'm sorry, I'm audible to everyone?
Yeah.
Okay, thank you, Dr. Jitender and Aditi ma'am and our President Sushant ma'am for this nice structure program for trainee and fellows. And thank you, our module moderator, Mishra sir. And after a long time, I'm sharing the screen with our legendary Professor Arvind Bagga sir. Thank you, sir, for staying with us and presenting such a nice lecture. I think sir has covered almost all of these things from the part of the steroid-resistant nephrotic syndrome. And I doesn't have much more to add on the topic, but I'll do the things that putting the information in the case-based scenario so that our understanding it bit clarified actually. Okay, just to let you know before moving to the case, I'm at Jammu and Katra. So, but I'm connected to the Wi-Fi, so network would not be a problem. So I think so. Let's start with the first case. So it's a 5-year-old boy, Souris, presented with a history of nephrotic syndrome that begins at 1 year of age. He has had 4 relapses in last 10 months. The most recent relapse occurred in 5 months ago. Since then, child is on prednisolone at the rate of 60 mg per meter square per day. But till urine protein is 4 plus, urine protein creatinine ratio is 4.2 milligram per milligram. Serum creatinine is normal, 0.3 milligram per deciliter. So what is the next best step in this situation? Option A, review the medical history and wait for another week for hoping the response. Option B, do kidney biopsy, send sample for genetic study. Option C, start calcineurin inhibitor. And option D, give 3 methylprednisolone pulse. Please put your response in the Q&A box, so it will be more interesting and interactive. So I'm moving to the things there, explaining the things. So its most appropriate answer would be review medical history and wait for a week. So as Saris already mentioned that we are now saying that at least 6 weeks of full dose steroid before declaring that is a case of steroid resistant nephrotic syndrome. So our case is Souris receive only 5 weeks of steroid. So still we have to wait for another week to assess the steroid responsiveness. Before that, we should also check the medical history, like the drug he is taking, because in small kid, the syrup formulation is available in like 1 ml equal to 1 mg, another is like 1 ml equal to 3 mg. So bit of confusion from the pharmacy also. So you have to check the drug dosage and formulation. Sometimes they vomited out the medicines because of the test, and mother is not repeating the dose. And sometimes they have some illness, they not took the medicines. So altogether you will check before saying that is a steroid resistant nephrotic syndrome. Also, as sir mentioned, that we should screen for the viral infections like hepatitis B, C, HIV for co-infections, because this infection has a different way of management. It doesn't need any immunosuppressive medicines. And also we need to screen for the systemic infection, because presence of systemic infections can interfere with the response to the steroid. So you should screen for infection and check the and treat the infection appropriately, so that we can say that steroid is not working here. And if the child need a kidney biopsy, if it is entering into the steroid-resistant nephrotic syndrome after 6 weeks, so the main chief indication, as I mentioned, just highlighting few points here, that kidney biopsy mainly done for the identifying the pathology that will give some idea about the prognosis, and is there any chronicity. The chronicity is also the much important for the prognostication, and to rule out the other systemic disease like systemic vasculitis, IgA nephropathy, and other systemic causes of nephrotic syndrome. And another indication for doing biopsy like CNI toxicity, that mainly done after 2 to 3 years of CNI exposure. So genetic study mainly done in case of congenital nephrotic syndrome and those who are initial steroid resistant nephrotic syndrome. So I'm going back to the Souris is a secondary or late resistant nephrotic syndrome. So here doesn't need any genetic study for him. Nephrotic syndrome with external feature, those are syndromic SRNS. those who have a family history of steroid resistant, and those who not responded to the therapy with the CNI and prior to the transplant. These are the chief indications for doing genetic study in steroid resistant nephrotic syndrome. Regarding the fourth option, giving 3 IV methylprednisolone pulse. So that is mentioned in some expert and few center also using that protocol also. But the conversion rate is very low, and the controversy is there to giving the steroid to get a steroid sensitive nephrotic syndrome. That's why the current guideline is not supporting that kind of therapy. So if you follow that currently published IPNA guideline, this is the timeline for managing nephrotic syndrome. So at 4 weeks of full dose steroid, you check the steroid responsiveness. So if it is complete remissions, there's a different management protocol, that is 6 + 6 weeks of steroid for steroid sensitive nephrotic syndrome. But if you have a partial remission or no remission, then you think about is going to have a steroid resistant nephrotic syndrome. And the week 4 to 6 is a confirmation period. At that time, you have you have to plan for genetic study and histopathology, and along with you continue the steroid. You can add the antiproteinuric agent like SC inhibitor and angiotensin receptor blocker. And you can, I'm just already mentioned that methylprednisolone pulse that doesn't supported by the current guideline. And after the 6 week, you have to define that it's a steroid resistant nephrotic syndrome. And if you have, by the time the genetic report is available, so you can divide this in genetic or non-genetic, then you can decide immunosuppressive medicine is either continue or stop. So the same case came at 3 weeks. So Soris is completed 6 weeks of prednisolone, but did not achieve remission. So we did a kidney biopsy, which suggestive of focal segmental glomerulosclerosis, not otherwise specified. And child was started on tacrolimus at the 0.2 mg per kg per day, and he's taking for last 3 weeks. But he admitted with swelling after an episode of oral candidiasis. Because he received a lot of steroid and this CNI therapy, he has a intense immunosuppression. That's why he has got oral candidiasis. So his parameter is like he has a anasarca, blood pressure is 100/60 millimeter mercury, urine protein 3+, serum albumin is 1.6 gram per deciliter, creatine is 1.5 mg per deciliter. So you can see that blood pressure is normal, but still nephrotic and proteinuria is there. Serum albumin is low, but creatine is very high. For a 5-year child, 1.5 mg per deciliter creatine is quite high. So he has got a AKI, acute kidney injury. So what is the cause of AKI here? Can you put your response to your Q&A box for that causes of AKI for Soris? Okay, so I'm going to the probable cause of AKI in this case. So it would be the CNI toxicities, sepsis, hypovolemia, use of diuretics, or the progression of the primary FSGS. So we check the tacrolimus level, that's called a TAC level, that is came out around 28 nanogram per ml. So normal target range is around 5 to 8, but it's quite high, much higher than the upper limit also. So probable cause of AKI is like tacrolimus toxicities. So can you say what is the why the TAC level is so high? Because the child is taking the normal dose 0.2 mg per kg per day. So why the TAC level is so high? Okay, so we have to monitor the child while on CNI therapy. So a guideline says that we need to check the CNI level, TAC level or cyclosporine level during the titration period every weekly. When the target level is achieved, then you can repeat 3 monthly at least. But when you have a confusion about the compliance or the drug toxicities and responsiveness, then you can check in between that. So drugs that increase level of tacrolimus or cyclosporine level, there's a big list maybe there are other drug also there. So I have put some drugs names here, like erythromycin, androgens, ketoconazole, metoclopramide, cimetidine, fluconazole, methylprednisolone, vancomycin, solindac, imipenem, calcium channel blocker, and some fruit juice like grapefruit and grapefruit juice. So he has oral candidiasis. Probably he was treated with fluconazole kind of medicines. That's why the tacrolimus level is high. And that some drugs that decrease the TAC level like phenytoin, phenobarbital, isoniazid, rifampicin, carbamazepine, heparin, and warfarin. And some drugs that potentiate nephrotoxicity of the calcineurin inhibitor, because the both combination of the two nephrotoxic are going to be a danger. So drugs like aminoglycoside, phenobarbital, amphotericin B, rifampicin, acyclovir, sulfonamide, captopril, and non-steroidal anti-inflammatory drug. These are the drugs that can potentiate nephrotoxicity. You should have avoided such drug while treating the child with calcineurin inhibitor. So now that sore is again readmitted with swelling, decreased urine output. The swelling was managed with injection albumin and diuretics, but urine protein still 4+. This time we check 24-hour urine protein, and that is 4.8 grams per day. It's like more than nephrotic proteinuria. And mother is asking for, is there any alternative treatment for his son? So what will be the next step in the situation? Option A, stop tacrolimus, as after 4 months the child is not showing any improvement, and give another drug like injection rituximab. Option B, add another agent like mycophenolate mofetil. And option C, recheck TAC level and add like ACE inhibitor and angiotensin receptor blocker. Option D, give injection cyclophosphamide pulse. So what will be the appropriate option for him? Please put your response in Q&A box. Okay, so he received tacrolimus for 4 months. The guideline says that at least 6 months have to take the tacrolimus. If the child achieve at least partial remission, then it's okay to continue the drug. But if it is not respond till 6 months of therapy, then we can say it's a not respond to the CNI or CNI resistant nephrotic syndrome, steroid resistant nephrotic syndrome, and that treatment will be very complicated. So option is like use of rituximab or MMF, as sir is already clarified extensively, that can be used in steroid CNI resistant nephrotic syndrome. Combination of CNI and mycophenolate mofetil that create a intense immunosuppression. So it's like post-transplant triple therapy, but the child in steroid resistant nephrotic syndrome already has a good amount of immunosuppression. On the top of that, if you use a CNI and MMF, it will going to create another risk of systemic infection. So better to avoid that such combination. And lastly, that IV cyclophosphamide monthly. So it's used as when the CNI is not available and it's not affordable, and there is a side effect like hypertension and cosmetic side effect that not acceptable by the family, or other contraindication of giving the CNI. In that situation, cyclophosphamide can be used as a second agent compared to the CNI. Now come to the case 2, is a 8-month male child, Mohammad Faizan, presented with anasarca. He is on prednisolone 60 mg per meter square per day for last 6 weeks. So he has filled the criteria of steroid resistant nephrotic syndrome. That's why we did the kidney biopsy, which shows focal segmental glomerulosclerosis. We also did the genetic analysis as the initial onset nephrotic syndrome, and we found we got the report of NPHS2 porcine mutation, and which is pathogenic variant. Now the edema is controlled with albumin and diuretics. So what will be the next step for managing Mohammad Faizan? Please put your response in Q&A box. So the recent IPNA and ISPN guideline not recommend immunosuppressive medications in case of monogenic mutations. So here the child has got a report of initial resistant nephrotic syndrome with protein mutation, that is pathogenic variant. So pathogenic and likely pathogenic variant with SRNS doesn't need immunosuppressive medicines, because the immunosuppressive is not going to help to achieve remission. It will going to create a lot of side effect only. The agent that reduce proteinuria, that is the antiproteinic agent like ACE inhibitor and ARBs, because the proteinuria is the only parameter that is going to create glomerulosclerosis and tubular damage, and first in the child to enter into the end-stage renal disease. So ACE inhibitor and ARBs recommended for all patients with SRNS. So guideline says to start these medicines at the confirmation period, that's after 4 weeks of steroid when the child is not responding. So it has reduced 30 to 40% of proteinuria in SRNS. So as a dual blockage, sir mentioned, because of the side effect like hypertension, it can cause AKI and hyperkalemia. So both dual blockage is not recommended right now. But what we can do, that we can use the maximum, the upper limit of dosage of ACE inhibitor or ARBs. Single agent is enough to continue. But be cautious, this agent while the child is in hypovolemic state like vomiting, diarrhea, infection, because in that situation, it can create a acute kidney injury. Some targeted therapy for after the genetic report is available, we can give like coenzyme Q for supplementable to Q10 pathway mutation. Some mutation respond to the corticosteroid like RO, RAC, and CDC40, NET2. And eplerenone like aldosterone receptor blocker also work in ARH DIA mutation. So the genetic report will help in some patients, but not for all. Now, going to the third case, is a 12-year female child referred to us for management of SRNS. She was evaluated for poor growth and found to have nephrotic syndrome. She received daily corticosteroid for last 6 months, but did not achieve any remission. And blood pressure is 120/70 millimeter mercury, edema present, urine protein 4+, serum albumin 1.8 gram per deciliter, creatine is high, 1.2 milligram per deciliter. We checked the medical history, no positive family history of kidney disease or growth failure. So we did the kidney biopsy that suggests to focal segmental glomerulosclerosis. And also we did the genetic analysis because child is not responded steroid. So it's a initial resistant nephrotic syndrome. And mutation, we found the mutation in the donor splice site in intron 9 of WT1 gene, and that is pathogenic. So what else to be done for this monogenic mutation nephrotic syndrome? Please put your response in Q&A box. Okay, so we did the karyotype because we have a genetic report, and we did the karyotype. We can see the karyotype report is here. We can see it's a female child with karyotype shows 46XY. It's a male type of karyotype. So female phenotype with 46XY. It's diagnosis of Frazier syndrome. 46XY female with gonadal dysgenesis. They usually present with SRNS and FSGS, but they could present with end-stage renal disease or CKD. There is a risk of gonadoblastoma. So we need to screen them regularly for that gonadoblastoma and take the appropriate action accordingly. So now coming back to this is the last case I am giving here. This is the case of Souris. He again came back with, he was a steroid-resistant nephrotic syndrome with FSGS, not otherwise specified, and was not responding to tacrolimus. The last visit at 4 months of tacrolimus, and then lost to follow-up. As the mother was not satisfied with our treatment, he lost to follow-up. And according to father, child was improving with the homeopathic treatment. So they choose alternative medicines for better response. And father saying the decreasing proteinuria, but the last few weeks, he has progressive weakness, breathlessness. We check the blood pressure and BP is 130 by 94 millimeter mercury. That is high for this child, 5-6-year child. Edema present, hemoglobin is bit low, 6.8, anemia present, serum creatinine is 5.2, urea 188 milligram per deciliter. The both are sky high. So as there is a uremic complication and we did the ultrasound and we find that the kidney size is reduced and echogenicity increase. So it's look like end-stage renal disease with uremic complication. So he received daily hemodialysis for 4 days. Now father is asking for the permanent cure. So as the family is willing for treatment, so we look for the kidney transplant. So now the question is that he is a FSGS, secondary late resistant nephrotic syndrome, and now is a end-stage renal disease. What is the chance of recurrence after the kidney transplant? Please put your response in Q&A box. So information is already explained to you by Sir. So what is the chance of recurrence after first kidney transplant? Okay, so moving to that actually. So if it is recurring allograft around 30%, so 6 to 50% is the range. Recurrence is associated with allograft dysfunction and lost about 40 to 60% patient. Recurrence risk is highest in patient with late SRNS with the prior transplant. That is the second transplant. It's more than 80%, up to 100% also. But patient with confirmed genetic mutation with underlying SRNS is good outcome after transplant. Recurrence rate is less than 5%. So I'm just summarizing my talk here, that management of SRNS is continuing to be challenging. So it is recommended that the pediatrician should refer the patient to the higher center with those who have experience with the managing SRNS and with the pediatric nephrology facility available, because they have a lot of things to do like biopsy, genetic testing, management of the complication. So don't try to manage in your setup, better to send them for diagnosis and send them to the other equipped center. Patient not respond to the treatment with the CNI at high risk of progressive kidney disease, they have a chance to end-stage renal disease also. SRNS, those who have underlying genetic etiology, they usually not respond to the immunosuppressive therapy, and they usually enter into the end-stage renal disease. But they have a good news that they rarely, very less chance to recur after kidney transplant. Thank you so much. So we will ready to get the questions if you have.